Hello everybody. Today we are going to start with another topic which is congestive heart failure. Your main function of your heart is to pump out blood. So this blood generally it goes and it fulfills your metabolic requirement of your body. So whenever your heart does not give out enough cardiac output to fulfill your metabolic needs of your body, then your heart is said to be under failure. So that condition is termed as a heart failure. So let us look at your definition of your heart failure. It is the heart failure denotes the failure of your heart to pump enough blood to meet your metabolic needs of your body. And normally, this pumping of your blood is not adequate whenever your filling of your ventricles is up to an optimum level, or your heart meets your metabolic need of your body only when there is increased filling pressure of your ventricles, that is whenever your heart is being filled up more than your normal amount. Okay, so whenever we talk about your heart failure, first and foremost there is decreased amount of cardiac output, due to which there is no proper supply of blood to your body parts, because of which your metabolic needs of your body parts or tissues is not met, so it is heart failure. Another condition is, or in some cases what may happen is, your body or your heart is pumping blood, you have optimum amount of cardiac output, okay, being supplied to your body tissues, you have an optimum amount of cardiac output going and supplying to your body parts or your different body tissues, but your requirement, your metabolic requirement of your body is so high that this cardiac output does not fulfill it. So under that condition also your heart is said to be under failure, and generally this occurs whenever a person is suffering from hyperthyroidism. This is hyperthyroidism. Your body is providing, your heart is providing your body with adequate amount of cardiac output, but because your metabolic need of your tissues has been heightened, this cardiac output does not meet its requirement. So under those conditions also, that is, your heart is said to be under failure. So see, whenever we talk about supply to your heart, we have to talk about your cardiac output. Cardiac output equals to stroke volume into heart rate. Okay. So for your heart to supply blood out of its ventricle, okay, this is your supply blood out of its ventricle, your ventricle has to be filled with certain amount of volume of blood. So at your end of your diastole, okay, end of diastole, that is your relaxation of your heart is going, your ventricles is going to have a certain volume of blood. That volume is known as your end diastolic volume, and it accounts for around 130 ml. Okay. Your heart is relaxing, so at the end of your diastole, or at your end of your relaxation of your ventricles is going to have certain volume of blood to it. So that volume is known as your end diastolic volume, and it is around 130 ml. So from this 130 ml per beat of your heart, whenever your heart beats once, which is your stroke volume, your heart gives out around 70 ml. 130 is getting filled up, correct? Out of that 130 ml per beat, per contraction of your ventricle, it is giving out 70 ml of blood. And this, per minute your heart beats around 70 times. That is, your heart rate is 70 beats per minute. So 70 ml and 70 ml, it generally gives you your cardiac output of around 5 liters. Okay. And one and under condition of your heart failure, okay, whenever a person is under heart failure, there is a decline in this cardiac output being produced by your heart. So whenever your heart beats, it is going to eject certain amount of blood, and your amount of blood that is ejected per beat can also be known as your ejection fraction or ejected fraction. Okay, ACTION. Per beat, certain fraction of blood from your ventricles come out. That is known as your ejection fraction. And generally, under normal condition, this ejection fraction is more than 50%. It is more than 50%, but a person under cardiac failure or your heart failure, your ejection fraction is below 45%. And for your people to show symptoms of your cardiac failure or your heart failure, your ejection fraction goes below 35%. Okay, so let's see, cardiac output equals to your stroke volume and your heart rate. Your stroke volume of your heart depends upon three major things. Okay, your stroke volume of your heart, it depends upon three major things. Those are preload, okay, and your three important things upon which your your stroke volume depends is preload, one, second is afterload, and third one is your contractility of your heart. Okay, stroke volume depends upon preload, afterload, and contractility of your heart. So what is preload? So we talked about end diastolic volume. So preload is nothing but end diastolic volume. So more your preload, right, more your work your heart has to do. So if your preload of your heart increases for a very long duration of time, it is going to cause your heart failure, because it is increasing your tension in the walls of your heart, as well as it is increasing the amount of work your heart has to do in order to pump out blood. So if you increase your preload, then this preload can further damage your heart and lead to heart failure. Second one is afterload. So let's see your ventricles over here. Your ventricles is getting filled up by your blood, right, left ventricle. So it has to come out, push this, your ventricles is getting filled up from your blood. So per systole, okay, per contraction of your heart, it has to open up this valve, one, so it is going to require some amount of pressure. And second, all your vein, all your arteries, your blood vessels, they contain certain amount of pressure. They are under pressure all the time. So for your heart or for your ventricles to pump out blood, it has to have a certain pressure which can overcome your pressure being provided by your valve as well as your blood vessel. So afterload is your resistance that your left ventricle has to overcome in order for your blood to undergo your circulation. Only if your pressure of your heart is higher than your pressure being provided by your arteries and your pressure being provided by your valves, then only your blood from your ventricle is going to come out. If not, if your pressure is less, then it is not going to come out. So increase in your afterload will cause decrease in your cardiac output. So there will be heart failure. And lastly, I said is contractility. See over here, your heart is contracting again and again, right? 70 beats per minute. So higher your contractility, greater will be your cardiac output. Lesser your contractility, lesser will be your output. So any disease which is going to affect your contractility of your heart is going to decrease your cardiac output, which is going to lead to heart failure. I hope till here it is clear. Next is compensatory mechanism that your heart undergoes whenever your heart is providing less amount of cardiac output. So your heart is under failure, correct? Which means there is decreased amount of cardiac output. So first type of compensatory mechanism is, first type is neurohumoral compensatory mechanism. Okay, first is a neurohumoral mechanism. So in this, what happens is there is realigned amount of cardiac output. So whenever this cardiac output is decreased, it is going to flow into your arteries. It is going to go and act on your baroreceptors. So whenever there is less amount of carotid sinus firing taking place, this information is going to go to your cardiovascular center present in your brain. So your CVC gets an information saying, I am getting, your heart is providing less amount of blood to your body. So your CVC, what it does is it goes and it causes sympathetic discharge. That is, it is going to go and activate your SNS, sympathetic nervous system. So there is going to be sympathetic discharge. So generally this discharge is of your norepinephrine, okay, or your noradrenaline. This noradrenaline is going to go and act on your heart. After it goes and acts on your heart, it increases your force of contraction, correct? It is going to go and increase your rate of your heart rate. Apart from doing that, what it does is it is also going to go and increase your preload, as well as it is going to go and increase your afterload. Generally this norepinephrine, what it does is it goes and it contracts your blood vessel as well. So contraction of your blood vessel is going to cause increase in your afterload, right? So if your afterload increases because of contraction of your blood vessel, because contraction of your blood vessel will increase your amount of resistance being applied by your blood vessel on your ventricles as well. So these three things, that is your force of contraction, rate of contraction, and your preload, is going to increase your cardiac output. Second is in your neurohumoral transmission or in neurohumoral mechanism. What generally happens is there's decreased amount of cardiac output, so your blood entering into your kidney is going to be low. Okay, because your blood in your kidney is less, what happens, your kidney, it activates your renin angiotensin aldosterone system. Because of your activation of your renin angiotensin aldosterone system, what generally happens, your angiotensin 2 is getting activated, which is going to go and increase your blood volume. Okay, so if there is increase in blood volume, there is going to be increase in your preload. Second is angiotensin 2 is going to cause vasoconstriction. So since there is vasoconstriction, your afterload increases. And lastly, there is going to be remodeling of your structures of your heart as well. Okay, this is the first compensatory mechanism, which is your neurohumoral compensation. Uh, Apart from these two, that is your norepinephrine and your renin-angiotensin aldosterone system, in case of your neurohumoral mechanism, there is release of your atrial natriuretic peptide. Okay, so first one was noradrenaline, second one is renin-angiotensin aldosterone system, and third one is atrial natriuretic peptide. Your atrial natriuretic peptide acts just opposite to that of your renin angiotensin aldosterone system. Okay, it is exactly opposite to that of your renin angiotensin system. How it is opposite is, first, renin aldosterone is causing your water, increasing your water reabsorption. In this case, ANP, what it does is it increases your process of urination. Second, renin angiotensin, what it is doing is it is causing vasoconstriction. Your ANP, what it does is it causes vasodilatation. Okay, so another system in case of your neurohumoral is ANP activation, and ANP acts exactly opposite to that of your renin angiotensin aldosterone system. Okay, another one is myocardial changes. And before we go to your myocardial changes, we'll talk about another compensatory mechanism, which is your Frank Starling mechanism. Okay, so this is also a compensatory mechanism. In case of Frank Starling mechanism, whenever there is increased amount of end diastolic filling volume, okay, your volume, there is increase in your preload. Okay, this increase in your preload is going to cause stretching of your cardiac muscles. Okay, it is, since more amount of volume of blood is present inside the ventricles, what is going to happen, your heart muscle is going to stretch more. So there is going to be stretching of your heart muscles, as well as there is going to be dilatation of your heart. Okay, it is going to dilate more. Since there is more stretching, what happens, there is going to be increased, it is going to increase your contraction. Okay, your force with which your heart contracts increases, that is your force of contraction of your heart increases. More amount of blood, more amount of stretching, correct, more dilatation of your heart. Due to this more stretching and dilatation, your heart contracts with more force, and because of this increased amount of force of contraction, your cardiac output also increases. Okay, increase in your cardiac output. Okay, there is increase in your cardiac output is there. Because of this increase in your cardiac output, it is able to maintain your requirement of your body. Okay, maintain your tissue needs. So whenever this happens, your heart is supposed, or your heart is said to be under compensated heart failure. See, heart failure is whenever your body is unable to supply enough cardiac output, or is not able to, wherever your heart, there is a decline in your cardiac output to meet your general requirement of your body, right, under normal filling pressures. But whenever it is increased filling pressure and it maintains your required metabolic needs of your body, it is known as your compensated heart failure. So however, okay, if this process continues for a very long time, same thing continuing for a very long time, that is, if there is your dilatation of your heart is taking place more and more, as well as there is stretching of your heart taking place, there is always going to be increase in your tension of your walls of your heart, due to which there is also going to increase your oxygen demand of your heart. And with time, what happens is, since you are putting more pressure on your heart muscles, your heart beating, or your force with which your heart contracts, is also going to decline, and because of which there is going to be decline of your cardiac output as well. So if there is decrease in your cardiac output, even with increased filling of your ventricles, your cardiac output does not meet your need of your body. So this is known as your decompensated heart failure. We come to your another compensatory mechanism, which is your mitochondrial myocardial changes, that is a myocardial structural changes. So these structural changes can occur in two different cases. Two different types of structural changes can be there. Number one, if there is your structural changes occurs because of increased pressure overload, okay, that is in case of hypertension, or in case of your valvular stenosis, okay, there is increased pressure load, that is there is increased afterload taking place. So under this condition, though your heart cells cannot divide, okay, after they have grown, what happens is there will be development of new sarcomeres, okay, there will be development of new sarcomeres, generally on your adjacent part. You have your sarcomeres over here, so there is generation of new sarcomeres on your adjacent side of your already present sarcomeres. Because of this production or new sarcomeres developing, what happens is your thickness of your heart wall increases. So therefore there is going to be decrease in your size of your chambers of your heart, okay. This is your heart, this is your myocytes. So normally your cardiac muscles, they do not reproduce, they are not reproducible, but your cardiac myocytes, they have your sarcomeres. So under this condition, your new sarcomeres, they start to develop, okay, they start to develop. Because of development of new sarcomeres, your thickness of your walls of your heart muscles also, they increase, okay. So this is increasing. So generally there is going to be increase in your heart size, but your chamber, your size of your chamber, that is your size of your ventricles, they do not increase. This is in case of your increased pressure load. Second is in case of increased volume overload. In case of increased volume overload, okay, now you have more amount of preload in your heart. So in this case also there is going to be development of new sarcomeres, but in this case generally in series, it is not going to take place on your adjacent sides, so they are added in series, due to which normally there is increase in your length of your heart muscles, or it causes dilatation of your heart muscle. So whenever your heart is under volume overload, they may there may be no change in your thickness of your heart, or they may be increase in your size of your heart, or it may also lead to decrease in your thickness of your heart. Either it will be the same, or they may be increase or decrease in your thickness of your heart. See, so this is your example of your structural changes. This is your normal. This is your normal heart. Okay. In case of pressure overload, see, your thickness is increasing. In your chamber of your heart, there is no change. Rather, there is decrease in your chamber size. Second is volume overload. Whenever more amount of volume is taking place, your length it increases, whereas your thickness may decrease or it can increase. But the proper change that you can see is there is dilatation occurring. There is dilatation over here. See, there is increase in your chamber size, which generally occurs whenever there is going to be volume overload. So this is generally hypertrophy of your heart is taking place. One major drawback of your compensatory hypertrophy is that is your myocardial structure changes is, see, your heart is increasing its size, right? In both the cases, this is increasing your size. So with increase in your size of your heart, there is going to be increase in your oxygen requirement as well. So your heart is already under failure, so further increase in your oxygen demand because of your hypertrophy occurring is going to cause further damage to your heart. So this is one of your drawback of your compensatory hypertrophy that occurs in your heart in response to either your pressure overload or your volume overload. This is sorry. This is a diagram showing how your cardiac performance of your heart decreases with increase in duration of time with decreased cardiac output. See, this is your decreased cardiac output. So your heart is under failure because you have a decreased cardiac output. In response to your decreased cardiac output, you are getting your compensatory mechanism, right? So in case of this, it is releasing your norepinephrine, renin-angiotensin 2, that is renin-angiotensin aldosterone system, as well as there is your release of your, this is endothelin is also being released. So norepinephrine can increase your contraction, force of contraction, as well as your heart rate. Apart from that, what it does is, all these three, what they do is they cause vasoconstriction as well. So because it is increasing your vasoconstriction, there will be increase in your afterload. If there is increase in your afterload, your ejection fraction, which we talked about earlier, okay, the amount of fraction of your blood that is getting injected from your ventricles is going to decrease. So if there is decrease in your ejection fraction, there is going to be decrease in your cardiac output with ongoing time. Same thing, compensatory mechanism, increase in your afterload. See how there is going to be decrease in your cardiac performance taking place with due course of time. Even though your heart tries to compensate for your decreased amount of cardiac output, but with due course of time, your cardiac performance high will decrease tremendously as well. Next is your okay. Next is now your heart failure may occur because of systolic dysfunctioning or diastolic dysfunctioning. When we talk about systolic dysfunctioning, this systolic dysfunctioning generally leads to heart failure by decreasing your myocardial contractility. Okay, that is, your systole is not taking place properly. The contraction of your heart is not up to your optimum level, because of which there is going to be decrease in your cardiac output. So normally this can occur in case of your ischemic heart disease as well as in case of your hypertension as well. Okay, can take place in case of ischemic heart disease, or you can say hypertension as well, it can occur. Okay, so your pathophysiology behind that is, so whenever there is decrease in your cardiac output, your perfusion to your blood, to your organs is going to decrease. The same mechanism that we did earlier in the case of compensatory mechanism. So there is going to be increase amount of SNS, the sympathetic system. There is going to be increased amount of RAS taking place, as well as vasopressin. So if you talk about your norepinephrine, it is going to increase heart rate, force, contraction. Second, your RAS as well as your norepinephrine can also increase constriction, afterload, preload. Okay, but see this negative sign or your sign in red. All these three fraction is going to inhibit your renal perfusion taking place, natriuresis, which is your excretion of your sodium through your urine, as well as your diuresis, that is increased urination, is going to be stopped. Whereas your same cardiac output, okay, when renin, angiotensin, aldosterone is getting activated and is going to increase your amount of blood volume in your body, what it does is this, first and foremost, it will inhibit your all this process, that is your vasoconstriction, afterload, preload process increase, it is going to stop, because they act just opposite to renin, angiotensin, aldosterone system. And on top of that, what they are going to do is they are going to they are going to decrease your renal perfusion, it is going to decrease your natriuresis as well as decrease your diuresis. So as an activation of your neurohumoral system will increase your cardiac myocyte hypertrophy, increase your cell death, increase your fibrosis, as well as cause arrhythmias. So basically increase in heart rate, force of contraction, blood pressure, vasoconstriction, afterload and preload leads to all these things. So second is your diastolic dysfunctioning. Now diastolic dysfunctioning can occur because of different diseases that is present in your body. Now when we talk about diastolic dysfunctioning, it is basically your inability of your heart to relax. Okay, so your ventricles, they lose your capability to relax more. So basically with your diastolic dysfunctioning can occur because of different diseases, again hypertension, diabetes, your coronary artery disease, obesity can lead to diastolic dysfunctioning. Because of all these diseases can lead to your cardiac myocyte hypertrophy. Okay, well, because overload is taking place, so there will be decrease in your cardiac myocyte hypertrophy. There will be cardiac myocyte thinning, and as well as interstitial and perivascular fibrosis, because your damage to your heart is going to take place, as well as your thinning of your cardiac myocytes, stiffening can take place as well. Now, since it is hampering your fibers, your cardiac myocytes, as well as fibrin threads are getting formed, as well as there is your hypertrophy is taking place, it will lead to diastolic relaxation defect. Your stretching effect of your heart is decreased. Secondly, there is going to be reduced regulatory reserve. So because your stretching is not taking place properly, your reserve is also going to decrease in your ventricles. Because of all these factors, it can lead to pulmonary congestion, it can lead to peripheral congestion, it can lead to decreased output. Pulmonary congestion, peripheral, and decreased output are your outcomes that you see. Your heart failure can either be on your left side of your heart or your right side of your heart. So it can either be your left-sided heart failure or right-sided heart failure. In case of your left-sided heart failure, your left-sided heart failure can be caused either by ischemic heart disease, myocarditis, valvular heart disease, or a restrictive pericarditis. And mostly whenever your left-sided heart failure is taking place, okay, you have your decrease in your cardiac output, and there is going to be decrease in your systemic perfusion. Your blood supply to your different parts of your body is going to decrease, so there's your tissue anoxia is going to take place, less amount of oxygen is going to take place, there's going to be renal perfusion is going to decrease. And again, since this is a left-sided heart failure is taking place, your left side is getting damaged, there is going to be congestion taking place in your lungs. Okay, there's going to be blockage of your blood in your lungs, because from your lungs your blood is going to come and enter into your left ventricles. Because your left heart failure is taking place, generally you see signs such as dyspnea occurring. That is your shortness of breath, and this is your first sign that you see in case of your left-sided heart failure. And as time progresses, dyspnea can lead to orthonia. So, and now generally orthonia is a condition in which you get your shortness of breath even when you lie down. Okay, dyspnea for earlier time, it is only when you are putting your body on the exertion. But when time progresses, even while you rest, or when you rest lying down on your bed on your supine position, that time also you get shortness of breath. And generally this happens because when you are standing, okay, that time your volume of your blood remains back in your legs, but on your supine position from your lower body, the flow of blood can take place on your upper area more effectively, and because of this there will be more congestion taking place in your diaphragm and your lungs. So orthopnea can occur as well, and there is always going to be cough associated with left-sided heart failure. Second is your right-sided heart failure. Generally whenever any side of your heart is being affected, your left side is getting affected, it can go and lead to damage to your right heart as well, because they are correlated. Your pumping of your blood from your left and your right heart is correlated. So right sided heart failure is basically a consequence of your left sided heart failure, because so your right sided heart failure, whenever it is taking place, there will be increased pressure in your whenever your left sided heart failure is taking place, there is always increase in your pulmonary circulation taking place. Because there is increase in your pulmonary circulation taking place, because left sided heart failure is causing accumulation of blood in your lungs. Because of this, what it leads to is it is going to be cause damage to your right sided heart as well. So left arterial pressure and volume, residual blood in your left ventricle is going to increase, because of which there is going to increase your arterial pressure and volume as well, because of which there is increase in your pulmonary vein circulation, which will lead to pulmonary arterial hypertension, which finally increases your right ventricular pressure. So generally what you see is systemic venous congestion is taking place. In case of left sided heart failure, there was edema occurring. In case of your lungs, pulmonary edema was there. But whenever your right sided heart failure takes place, there is edema occurring throughout your body, throughout your peripheral parts of your body. Okay, so this is your left sided heart failure and your right sided heart failure. Um, your compensatory mechanism, what is your outcome of your compensatory mechanism? Both your left sided ventricular failure as well as your right sided heart failure, there are two different types, will initiate your compensatory mechanism. So in both your case, see, there is activation of your non-epinephrine ANP, as well as there is activation of renin-angiotensin aldosterone mechanism. Both your ANP and your non-epinephrine is going to cause tachycardia, that is increased heart rate. Second, there is water and sodium retention by your renin-angiotensin aldosterone. One part is increasing your volume of blood in your body. Second part, your another, that is your non-epinephrine and ANP, is increasing your rate, your working capacity of your heart. So both are causing stress in your myocardium. So with due course of time, again what happens is heart failure. Second is there's increased myocardial contractility. So workload is increased, cell stretching is increased, hypertrophy and dilatation of your heart takes place. So with this we complete another topic, that is your congestive heart failure.